Welcome to Chapter 15, Obsessive Compulsive and Related Disorders. Brief overview. OCD was previously classified as an anxiety disorder. However, it's now recognized as a distinct disorder due to its very unique characteristics. Do not confuse obsessive compulsive disorder with obsessive compulsive personality disorder. These clients have repetitive thoughts and behaviors, whereas your personality disorders are those rigid thinkers that are perfectionists. Related disorders, we have some self-soothing behaviors such as trichotillomania. We have reward-seeking behaviors like kleptomania, and body dysmorphic disorder will also be discussed in here. The DSM-5 officially recognizes OCD, body dysphoric disorder, hoarding disorder, trichotillomania, and some other disorders that can be linked to substance use, medications, and other causes. Key terms that you need to know, learning objectives that we'll cover in this lecture. So, obsessive compulsive disorder overview. This can start in early childhood. It's more common in females, and it usually begins in 20s. Periods, clients can have waxing and waning of their symptoms over the lifetime. We can have early onset and we can have late onset. So the obsessions are going to be recurrent, persistent, intrusive thoughts, images, or impulses. They're going to cause significant anxiety and interfere with daily functioning. The client usually recognizes these thoughts as excessive, but feels powerless to stop them. The compulsions are the behaviors. These are performed to reduce anxiety, often directly related to the theme of the obsession. In the next slide, we'll discuss more about them. So remember, obsessions are the thoughts, compulsions are the actions. So our actions. We can have checking rituals, which is repeatedly verifying doors are locked, appliances are off. They might have counting rituals, such as counting steps, objects, or patterns. We can have excessive washing, praying and chanting, touching, rubbing, or tapping, ordering and arranging, rigid performance following an unchanging routine in daily, right? So that's not the same as the personality. This rigid performance is about constant daily routines. They can also have aggressive urges, which are unwanted impulses, such as thoughts of harming loved ones. OCD can significantly impact an individual's personal and professional life, requiring therapeutic intervention and, in some cases, medication management. So, our related disorders. Excoriation disorder is self-soothing behavior. It is commonly done to face, fingers, hands, arms, legs. It can cause distress, embarrassment, and medical complications. The treatment for this requires medications, surgery, psychiatry, and alternative therapies. And this is just skin picking. The client just picks at their skin. Trichotillomania, which is hair picking, also is self-soothing. Its onset is typically in children. It can persist into adulthood. It's more common in females. It's treated with behavioral therapies, SSRIs. Clients with this can develop a hairball mass that turns into a surgical intervention. The chronic nail biting, also considered self-soothing, also started in childhood, typically decreases around 18, but can persist into adulthood. Treatment for that is SSRIs and cognitive behavioral therapy. Body dysmorphic disorder is a preoccupation with an imagined or slight defect in appearance. This causes significant distress and functional impairment. It's frequent elective cosmetic surgery. These clients are going to go for those. And then they're usually still going to be dissatisfied. Usually overlaps with anxiety, depression, social anxiety, and the excoriation disorder. Treatments for BDD are going to be SSRIs and discouragement of cosmetic surgery. Hoarding disorder, recently classified as a separate disorder, not a symptom of OCD. Onset's usually 20 to 30s. It's more common in females, and it's actually characterized by an excessive acquisition of items, cluttering living spaces, which can lead to health and safety hazards. Um, I've been told that it's less about the item and more about the loss of something, never being able to get it back. Treatment is medications, cognitive behavioral therapy, self-help groups, and community agencies. Then we have our reward-seeking behaviors. So we have kleptomania. Kleptomania is going to be compulsive stealing. This is the thrill of stealing, not the value of the item. It's more common in female. It has some comorbid depressions and substance use with it. It's associated with significant legal issues. Treatments, long-term therapy. There's really no standardized approach. And then oh, I don't have pyromania in here. Pyromania is also one of these, and that is the fire setters. And then we have body identity integrity disorder. This is a desire for amputating of a body part. It's not officially accepted by the APA, the American Psychiatric Association. It's very controversial. Individuals may resort to self-harm or seek illicit amputation. A lot of ethical concerns around this, and I've never seen one of these people. All right, so your etiology, cognitive model. This is based on Aaron Beck's cognitive approach to emotional disorders. Key elements in the cognitive model are overimportance of thoughts, belief that thoughts occur, it will come true. So if I think it will happen, it will happen. Perfectionism and intolerance of uncertainty, striving for perfectionism and the inability to tolerate uncertainty, an inflated personal responsibility, often influenced by a strict moral or religious upbringing, leading to overstimulation of threat poses by one's thoughts. We also have the focus on the childhood and the environment experiences as potential contributors. We also have genetic factors that we can look at. So population-based studies show substantial hereditary of OCD. Genome-wide and candidate gene association studies have identified genetic variations potentially involved in our OCD pathways, and evidence suggests that multiple genes could actually contribute to this genetic risk. Cultural considerations. So we have some religious influence. Highly religious individuals may experience heightened guilt about their symptoms. They often believe they should be responsible for controlling unwanted, threatening thoughts. Shame and guilt are common feelings among those with OCD and related disorders. Cultural beliefs. In some cultures, individuals with OCD may believe their symptoms are caused by supernatural forces. These beliefs can lead to seeking help from faith healers instead of traditional medical treatments. Prevalence of unwanted mental intrusions. These unwanted mental intrusions are a key feature of OCD and prevent across various cultural, religious, and nationalities. There was a study including individuals from 7 European countries that found 64% experienced unwanted mental intrusive thoughts, often associated with OCD, BPD, hypochondriasis, and eating disorders. So our treatment for these, if we're doing medications, your first line medication is going to be that SSRI. Usually these are higher doses than what we see with clients with depression and anxiety. Second line treatment, we might go to like venlafaxine. Treatment for resistant OCD might be our second generation antipsychotics. We can do behavioral therapy where we expose and response prevention, which is our ERP. So with the exposure, the client confronts situations and stimuli they typically avoid. And then response prevention, the client delays or avoids performing the ritual and learns to tolerate the anxiety, recognizing that it will recede without consequence. And then they can do a combination of those two. Other techniques, we can do deep breathing and relaxation. And then there's also some somatic therapies where we can do some deep brain stimulation where we implant electrodes, or we can do the transcranial magnet stimulation to help these clients. So what are you going to see on your assessment, right? We're moving into the ad pie of this. So your assessment, we're going to see somebody who's maybe seeking treatment. So clients typically seek treatment when the sessions become overwhelming and the compulsions interfere with their daily life. Hospitalization is rare. It occurs when clients, though, are unable to carry out daily routines, activities of daily living. Most treatment is found in outpatients. Clients report that rituals started many years ago, sometimes in childhood. As clients age and take on more responsibilities, rituals tend to interfere with more of their ability to fulfill those responsibilities. Our general appearance, the client may often appear tense, anxious, worried, maybe fretful. They may be embarrassed about their symptoms. Overall, their appearance may be unremarkable, though. Their mood and affect. Client may report overwhelming anxiety in response to obsessive thoughts, images, urges. They may appear sad and anxious. Their thought process. Obsessions often arise unexpectedly during normal activities. The harder the client tries to stop the thoughts, the more intense they usually become. The client recognizes the irrationality of these obsessions, but they cannot stop them. Intellectual functioning is typically intact, though concentration can be difficult during strong obsessions. There's no impairment in their memory, there's no sensory functioning issues. Their insight and judgment. Clients recognize that obsessions are irrational, but struggle to act on that realization. They may sound judgmental, but continue to engage in ritualistic behaviors to alleviate their anxiety. Their self-concept, they often feel like they're going crazy due to the inability to control the obsessions and compulsions. Feelings of powerless contribute to lower self-esteem. Clients may believe that they were stronger or had better willpower, they would be able to control these thoughts. Their impacts on their roles. These ritualistic behaviors increase the client's ability to fulfill their roles. Um, wait, as the ritualistic behavior increases, the client's ability to fulfill their roles decreases. Relationships may suffer as family and friends become tired of repetitive behaviors, and clients may become less available to loved ones due to being consumed by the anxiety and rituals. Some physiological effects, clients may experience sleep disturbances. They might have loss of appetite. They might have unwanted weight loss. In severe cases, personal hygiene may suffer because they're unable to complete the necessary task due to complications. Common associated problems with it, with OCD, we can have anxiety, ineffective coping, fatigue, low self-esteem, and even skin breakdown, because if they're doing the ritualistic washing, we can have that. All right, so, right, we've done our assessment. Now we're moving on to our data analysis. So we might have ineffective coping, low self-esteem, skin breakdown. Always top priority, safety, safety, safety. Monitor for suicide, sleep patterns, eating patterns, skin damage. Overarching goals, right? Clients should be able to be safe. They should spend less time performing their rituals. They should be able to complete their activities of daily living within a reasonable time frame. They're implementing their relaxation techniques. So your nursing actions, right? We want to make sure that we're using our therapeutic communication to support and encourage them and to normalize their experience. Clients may hide rituals and obsessions, so we need to openly discuss them to alleviate the burden that they're carrying in secrecy. We want to teach relaxation and behavioral techniques. So, relaxation techniques, deep breathing, the muscle relaxation, the guided imagery, especially when the client's anxiety is low. That's the best time to teach these when we have that mild anxiety, because we know when we get to moderate, we're not going to be able to learn anything. We want to initially demonstrate these techniques and then encourage them to practice them independently. When we talk about behavioral techniques, baseline record, right? Client needs to keep diaries so that they can identify triggers, note their anxiety, intensities, ritual duration, and behaviors that they're avoiding because of it. We can do exposure and response prevention, encouraging the client to gradually reduce ritual time, delays of ritual, or eliminating and minimalizing them. Client willingness, it's really crucial that the client wants to be engaged in using any of those techniques. Completing a daily routine. So schedule ritual time that allows the client to do their rituals, but they need to be able to make into their daily schedule things like, their activities of daily living, and then gradually reducing that so that they have less time on the rituals and more time on self-care. Providing client and family education, right? OCD education helps both the client and their family understand that OCD, what it is. It's not a reflection of the client's personality, and the obsessions are truly unwanted. Medication compliance, we need to teach the importance of medication adherence as it enhances effectiveness of the behavioral techniques. We want to provide emotional support, encouraging the family's involvement and open discussion to alleviate the client's guilt and provide emotional support. When we talk about evaluation, depending on what action we implemented would be how that we would evaluate it, right? So if we're looking at patient family education, your evaluation should be that they were able to teach that back to you, or maybe name 3 different relaxation techniques or perform the relaxation techniques for you. Again, this is just further about teaching, right? Because teaching is a huge part of what we, the nurse, can do, right? LPNs aren't teaching, RNs are teaching. Well, LPNs might be, but the ANA says RNs are the educators. So teach about the OCD, explain, that we understand that there's the intrusive thoughts that lead to those behaviors, open discussions, medication compliance, tolerance of anxiety. Emphasize that while the client um, has the anxiety, it can be uncomfortable, it's not harmful, and it will naturally decrease over time without engaging in the compulsions. For family, avoid offering simple solutions. Refrain from advising. Um, they don't need to be telling the client, just get over it. Just think of something else, right? We need to make suggestions to minimize the seriousness of the disorder and helps reduce their frustrations. Again, don't try to fix the problem. Make sure you're patient and monitor your own anxiety. Families should be aware that they're going to have an emotional reaction, and that's okay. They might need to take a break from the situation to avoid escalating their stress, especially when we're talking about our kids who suffer from this. So self-awareness issues, again, understanding OCD's rituals can seem irrational. It's very difficult for others to understand why some with OCD continues to perform seemingly senseless behaviors like hand washing until their skin is raw. These rituals are driven by intense anxiety, and it's not a conscious desire to act this way. Awareness of behavior, people with OCD know that their rituals may seem strange, but they perform them to relieve that overwhelming anxiety. Simple advice like just find something else to do can increase their guilt or shame. We want to avoid judgment. Nurse health professionals should recognize that OCD is not about stubbornness. The individual's anxiety prevents them from controlling their behaviors, even if they realize it's irrational. And this is also very chronic in nature. It's a long-term condition with symptoms that can fluctuate. Even if someone manages their symptoms for a time, they still might need ongoing support.